This presentation was recorded at the 2015 ANZICS ACCCN Annual Scientific Meeting.
Nick asked me about a year ago, said, we'd like somebody to come and talk about non-invasive ventilation. And I thought, who'd want to come and do that? So I asked Professor Burston, do you know anyone that would want to come and do that? And Professor Burston said, I'm not coming to Auckland, unfortunately, I'm on holiday. But I do know a man who knows a little bit about it. Now, I don't know if any of you have been to Adelaide, but when he says knows a little bit, it's usually a gross underestimation of the facts. And when you look at Associate Professor John Santamaria's bio, you'll see that he has a doctorate into the control of breathing, if you see what I mean, really. He's also trained in respiratory medicine and intensive care and works at St Vincent's in Melbourne. And he's going to talk to us this afternoon on who should get NIV.
Thank you very much. As you noticed, as the oldest and the shortest, you have to come up through the stairs. Get to come up there. And yes, I still practice in respiratory, and I do still have patients that I treat at home on non-invasive ventilation, so I'll be a little biased on this. So this is just a brief overview. Limited number of conditions with proven benefit, some conditions where it's not effective, and we've got a large area where we're unsure. And I want to, at the moment, the number of people who have obstructive sleep apnea who are included as being NIV in our units is increasing, and we should exclude that from any discussion. So what about a bit of terminology? Who should get CPAP, or if you like, EPAP alone? Well, acute pulmonary edema, positive studies. One of the authors is sitting in the second row here, George, but Andrew Burston's paper of 1991 showed that that's the treatment of choice for patients who have acute pulmonary edema. So, positive outcome, sorry about the Cochrane there, but it's well proven. EPAP plus IPAP, so PEEP plus pressure support. Well proven for people who have chronic neuromuscular disorders, so the Duchenne's, all the dystrophies, people with kyphoscoliosis, and COPD people admitted with exacerbation. Positive Cochrane reviews. We should be doing this. Mortality benefit. Do we use it just at night? Well, that's what we do with, certainly with a lot of the neuromuscular and kyphoscoliosis. But some of them are even requiring it 24 hours a day. It can be done non-invasively. Even the COPD people now are being put on it nocturnal to improve their respiratory muscle function. Well, what about other areas? Post-surgery, abdominal surgery, people having bowel resections done. It's a little confusing. There are two Cochrane reviews here. One using NIV in the post-operative period showed that there was a reduction in needing intubation, maybe reduced ICU stay, maybe a trend to decrease mortality, but suggesting we need more trials before we can recommend this. And a second one using CPAP showed a reduction in death, atelectasis and pneumonia, but still not enough evidence to make a recommendation that you should be using it in preference to other forms of therapy. Thoracic surgery, there's a big no for patients following lobectomy in the Cochrane reviews. It's not been shown to be benefit, may be harmful. And cardiac surgery, I don't think we know about it just yet. Other acute lung disorders, what about acute pneumonia, ARDS? Well, if Andrew was giving this talk, he'd say no. He'd say absolutely don't use it. It's probably dangerous to actually do. Acute asthma, little evidence. Cochrane has 6 trials. Some of them are positive for maybe shortest time in the ED. Maybe the lung function gets better a little quicker, but no longer term sort of outcomes to actually suggest. Should we use non-invasive ventilation to extubate that difficult ICU patient to prevent them being reintubated? There are papers out there suggesting, but again, I don't think there's enough to make a recommendation that it should be done in every person at this stage. So, EPAP, IPAP, and a backup respiratory rate. We don't often think about this, but I often do this in people who are really quite hypercapnic, apart from the acute pulmonary edema people. Neuromuscular, kyphoscoliosis and COPD. It's often how you get your CO2 down. And if we really are giving them respiratory muscle rest overnight, we have to stop them sort of breathing. So we have to give them a rate that's a little bit faster than what they're doing in order to turn them off. So I do think it's important in these group of people to make sure that we do something with rate. But what a lot of issues around non-invasive ventilation. How do you set them? What's the proper EPAP? How much PEEP do you put on? 5, 7, 10? How much pressure support do you use, and what do the machines go up to, and what respiratory rate should we be doing? What mask do we use? Full face mask, nasal? Do we use the little nostril ones that people use for obstructive sleep apnea? The head masks, and I put the diving bell, but you've seen the ones now that are being distributed out there. They look interesting. Do you use concomitant sedation? So that COPD patient who comes into ICU who doesn't like non-invasive ventilation, do you put them on a propofol infusion? Do you give them dexmedetomidine? Or do you have 4 nurses standing by the bed just holding them down so that they can be treated non-invasively? So I think there is a place for doing that. And you've probably seen also this year there have been, I think, at least 2 trials in the big journals wondering whether we should use high-flow nasal instead of non-invasive ventilation. There's been no, if you like, NIV versus placebo or high-flow versus placebo. There have only been these comparative studies, but we don't know about those places yet. So what do? Well, I thought I'd go back and see if I used evidence. So in the last 2 years, 10% of people had NIV hours, proper ones recorded. 30% of those were post-cardiac surgical patients, for which I've got no evidence for doing. 15% was COPD, 10% had intra-abdominal problems, 10% had APO, and 10% sepsis with hypoxia, and a large group have just mixed. So, if I wanted to summarise, green as go. So, CPAP, EPAP for acute pulmonary edema, mortality benefit. BiPAP for COPD, neuromuscular disease, kyphoscoliosis, good evidence. Unsure about atelectasis and asthma post-operative. I probably wouldn't use it in ARDS or pneumonia either. I think if you do, you've got to be really very careful. There are some worries that we might prolong proper treatment for them. And having respiratory rate as your backup for these group of people who have hypercapnia. Thank you very much.